What's your diagnosis? What's going on? That's all you're going to probably have, right? When you walk up there. So you have to call your senior, call your resident.
Could it be the UTI causing the delirium? I think that's a common presenting symptom in elderly people with UTIs.
Absolutely. So it can be a presenting symptom of any condition, but UTIs are very common. The caveat with that, and we always order urinalysis, is that it's often that plus something else. So you can't just stop and say, well, we'll just treat the UTI and we're good to go.
It could be like Alzheimer's or another dementia, because we have the lecture, they mentioned that it can often be masked until something abnormal happens and admitted to hospitals. So.
Right. So what they mean by that, so you wouldn't get a sudden awareness of someone changing. So if it was someone that was familiar with that person, a dementia will come gradually, but we don't know about it as a health professional until they come to hospital, because then we're like, well, how's this person functioning? Because they can't remember this and they can't remember that. Or another way it often is unmasked is the spouse is covering and then something happens to the spouse and they get admitted and suddenly mom or dad is at home and they're not able to function. So when we talk about unmasking a dementia, it's that they've had it, but no one else knew about it because either they haven't had a lot of contact with other people or someone's been covering it up. And it's when you take them out of their environment that they're familiar with that it really shows up. So it wouldn't, so you know, in this case where the daughter is saying, mom is not like this, then that would be a little bit different than dementia, okay? And that's a big differentiating point. A dementia never suddenly comes on, right? So when you think back to that chart that I first started with, acute versus subacute or chronic is your biggest, if you miss that question, you're gonna misdiagnose the patient, right? So, as I was talking about the chart, so cognitive impairment, if it's acute, we're assuming it's a delirium. So then we're going to talk a little bit about the approach to delirium. So diagnosis right now, all we know is she's delirious, right? So we know she's got a change from baseline, and we know there's a change in her cognition. How do you diagnose? Does anybody know if there's any diagnostic tools or tests or anything like that for delirium? Anybody familiar? I don't know if you guys learned that yet. It's called the CAM, so this is the Confusion Assessment Method. It's not perfect, it's kind of the tool that's been most used, and it's actually not a checklist, so it's not a questionnaire that you ask the patient like a mini mental or something like that. It's questions that you ask yourself from observation or ask the staff around you, and if they have certain criteria, then they might have delirium. So the first one is acute onset and fluctuating course. So this is key clinical features. You must have the first two that I talk about, plus either 3 or 4. So she must have an acute onset, which we do have, right? Her daughter says she's not normally like this, it's just happened since she's come into hospital. And fluctuating course. Did she have a fluctuating course? Yeah, did you hear that? Because we said the nurses said sometimes she's okay and sometimes she's not, right? So easily caught by that. You'll go in and see the patient as a student or a resident. They're fine, they're chatting with you, you come back with your team and she's totally confused and they're looking at you like, did you see the patient today? But that's a classical sign of them being that way, right? So we have fluctuations where sometimes they're good, sometimes not. And that's a really important question to ask the nurses, because they're with the patient all day long, right? So really important to ask, are you seeing that? What family that are in with the patients? The second one is inattention. So this is the other key point. So easily distractible. We did talk about that with her. So most patients, especially in hospital, when you come in to see them, they've waited all day for the doctor to come in to see them. They're going to be looking at you, they're making eye contact, they're focused on, okay, what's happening, what are you telling me, and here's my questions I have for you. If you come in and they're distracted and they're off on tangents, or someone walks down the hallway and they're looking to see who's there and they can't focus on you, that's a sign of inattention. Another quick, easy bedside way of checking for that is just to ask them to say the months backwards. So start at December and just say the months backwards, because that requires a bit of attention to be able to do that as well. So if you're not really sure, maybe they're paying attention and you can't really tell, then you could do that type of quick question by the bedside. So you have to have acute onset, fluctuating course, and inattention. So you must have those. And then one of either 3 or 4 or both. So disorganized thinking, this is when they're not really making sense, they might be paranoid about stuff, they might be seeing things, they might be thinking that people are talking about them, things like that. Now a lot of times people think when they think about delirium, that's all they think about. Someone who's hallucinating and picking at bugs and hearing voices, but not everybody has this. So if you use that as your diagnostic criteria, you're gonna miss a whole bunch of delirium, okay? And then the last one is altered level of consciousness. So this may be either hyperalert, which is the classical example when people think of delirium, the person who's trying to climb out of bed or is agitated, but it can also mean hypoalert. So this person who's really tired, sleeping all the time, and these are the ones that we miss the most. These are the patients that never really bring any attention to themselves because they're quiet, right? So they're not agitated, they don't bug the nurses or anything like that. But the issue is they're not eating, they're really not wanting to get up, they're maybe sleeping all the time, they're not really engaging in conversation. That is a hypoalert delirium. So their risk is no different than the person who's hyper, who's pulling lines. They could be having a heart attack and just sitting there. And we've had case after case after case where we do an ECG 3 days later and they queued up because they had a MI 2 days ago and been having angina for 2 days and we sat on it in hospital. So you have to be just as aware and of those types of patients. So with Mrs. B, what do you think is kind of putting her at risk and what could have triggered? So anybody can get a delirium. If you get into a big car accident and you're in ICU and you've got tubes hanging out of you and you're really, really sick, you could be delirious, right? You could be wake up and you're intubated and you don't know what's going on, you've lost all these days. For an older person, so it takes a lot to make us delirious, but for an older person, they have very little functional reserve. So they've got lots of chronic medical conditions, they may have some vision issues, some hearing issues, so it takes something very little to knock them over. So it can be a new medication could do it, UTI can do it, or anything major. So any of the big stuff like the heart attacks and strokes. In Mrs. B, the things that would set her up to be at risk is that she is older, so changes to her brain that would put her at more risk. She's on lots of drugs and she's got some sensory impairment. So she's got macular degeneration, can't remember if she had any hearing difficulties, but she may have that. She's got osteoarthritis, she's got diabetes, she may have some peripheral neuropathy. And then the precipitating factors in her could it be that she's having something going on cardiac-wise, she has a Foley in, she has a UTI, her benzo was suddenly stopped. So even though we don't like benzodiazepines in older adults, if a person comes in on a benzo, you don't just stop their benzo. You're almost guaranteeing that you're going to make them delirious. So it's something that we have to wean very slowly. She may be having pain because she's not getting her Tylenol, and so pain also can trigger. So these are all things that could be causing her delirium that we have to address as well. So what do we want to do with her? How are we going to help poor Mrs. B who's confused and not taking her meds?